Hello, my name is Ulysses Burley, and I am the founder of UBtheCURE LLC, a faith, health, and human rights organization where we treat people and not disease, based in Chicago, Illinois, of the United States. What faith groups can learn from the science, research, and information presented at AIDS 2020? Key findings from AIDS 2020: status, scientific update, and social dynamics of the HIV epidemic. One of the first sessions during the 2020 AIDS virtual conference was 2025 AIDS targets. And during this virtual session, there were three key points. These are the composite key points that will be touched upon during this presentation. And key points that are highly relevant for faith communities who do the work to end HIV and AIDS globally. Professor Stanley Okolo is the Director of General of the West African Health Organization, and he presented this outlining the vision, goal, and strategic objectives for which we all need to proceed to achieve an AIDS-free society by 2030. In it, he notes to strengthen the national and regional coordination and leadership, to generate and disseminate strategic information and normative guidance, to scale up targeted and comprehensive interventions, and to empower all key populations, ensuring that the human rights of key populations are respected. This presentation offered by Professor Okolo is a great summary of the key points that will be highlighted from AIDS 2020, the virtual conference, that specifically relate to issues of people of faith. In 2019, there were 690,000 AIDS deaths globally. 38 million people are currently living with HIV, with 1.8 million children living with the virus. There were 1.7 million new HIV infections, among which 150,000 were children, where 25.4 million of the 38 million people currently living with HIV are receiving antiretroviral therapy. However, we've only achieved about 50% coverage among children. And so we'll continue to hear this reoccurring theme around the ways in which we are responding to the HIV and AIDS epidemic, particularly among children and adolescents. Progress toward 90-90-90, which is that 90% of all people living with HIV will know their HIV status by the year 2020. That 90% of all people with diagnosed HIV infection will receive sustained antiretroviral. And then finally, that 90% of people receiving antiretroviral will have viral suppression. Has not been achieved. Up until 2019, we were at 81, 82, 88, falling short of our 90-90-90 target that had been established. Likewise, coverage of treatment among pregnant women was currently at 85%. Likely, we will miss the 2020 targets established by 90-90-90. And these were some of the main messages that we're lifting up. We know that the AIDS pandemic is fueled by inequalities, which is something that is particularly important for faith communities to consider, given the social standing of many faith communities around the world. And COVID-19 has further widened the gap in terms of these inequalities impacting the HIV and AIDS response. Some of the other key messages that emerged from AIDS 2020 that are relevant for faith communities was that despite high antiretroviral coverage among pregnant women in some regions, child new infections continue due to lack of retention and care, and women acquiring HIV during pregnancy and breastfeeding. Some 280,000 new HIV infections occurred among adolescent girls and young women between the ages of 15 and 24. Given the fact that we are in the midst of dual pandemics, both the HIV and AIDS global pandemic as well as COVID-19, one of those presentations focused on turning this crisis into an opportunity for multi-month dispensing of antiretroviral treatment for people living with HIV. COVID-19 crisis has in fact accelerated some of these innovations where people can receive their antiretroviral treatments for many months at a time to avoid serious disruptions to the HIV treatment that have been a consequence of supply chain disruption because of COVID-19. Annette Burster of the World Health Organization presented key slides on key populations. Slides that included sex workers, people who inject drugs, gay men and men who have sex with men, transgender people, and also sex worker and clients of sex workers and their sex partners as key populations. It was noted that opportunities and challenges of ensuring a broader health focus for key populations continues to exist. We know that more than 1 million STIs or sexually transmitted infections are acquired every day. An estimated 376 million new cases of curable infectious diseases were noted in 2016. STIs incidence and prevalence are high among key populations. But there are also, again, opportunities to integrate both sexual transmitted infections into key population PrEP services and peer outreach, into community-led approaches, and also into primary care. And so we continue to hear this theme around integration in terms of HIV and AIDS care, but also community-based initiatives. And this is a very key concept for faith communities because many faith communities are a part of the care provisions that take place in many places around the world and are also more connected to the communities that often need these services. It's found that MSNs living in African countries that criminalize gay sex are at a much higher risk for getting HIV, whereas countries where same-sex sexual activity was not criminalized, 8% of men who have sex with men sampled had HIV. And that number rose to 20% in countries with criminalization and increased to 50% in countries with severe criminalization. This is an important touch point for faith communities and faith leaders in that it's an opportunity to advocate against laws that criminalize same gender sex because data shows that those laws decrease access to anti-HIV services. And so the goal is to increase access. The goal is to promote human rights for all populations, and the goal is to build bridges of collaboration across key populations. And so faith communities can play a critical role in doing so. Likewise, we've seen the theme of integration mentioned many times. We've also seen this idea of community-led interventions being key. We see that with sex workers, community-led intervention actually interrupts STI and HIV transmission, and that there is a high uptake in utilization of basic condoms and STI services when actively promoted by their peer networks. It's important that faith communities are part of those networks that can continue to interrupt not only STI infection, but HIV transmission at large and advocate for this key population. All right, Craig McClure presented a slide on the global burden of hepatitis C virus, HIV, and tuberculosis among select key populations, with highlighting the impact in people who inject drugs. So people who inject drugs is another key population. Again, this idea of integration, of integrated programming comes into play where we can optimize client engagement with services, we can coordinate program management and enable financial efficiencies to achieve public health goals, specifically as it relates to people who inject drugs and likelihood for transmission of key sexual transmitted infections, including but not limited to HIV. Another key thing presented at AIDS 2020 virtual was PrEP, and more specifically, the integration of PrEP with sexual and reproductive health. But I want to highlight this particular study, HPTN 83, that targeted cisgender men and transgender women who have sex with men. It involved 4,500 to 5,000 participants spanning across Africa, Asia, Latin America, and the United States. And from this study, there were 13 incident HIV infections from people who were using cabotegravir as pre-exposure prophylaxis. And there were 39 incident HIV infections from people who were using standard tenofovir, emtricitabine, or Truvada as PrEP. And the conclusions that were drawn were that both agents were highly effective for HIV prevention. Regimen containing cabotegravir long-acting was superior to a daily oral regimen of emtricitabine and tenofovir. This is good news for the HIV community in that cabotegravir is the first long-acting injectable agent to demonstrate robust HIV prevention efficacy in men who have sex with men. And 1 year after this study, there's this integration in the time of COVID-19. This study suggests that there's an urgent need for investment in women's-centered programs that offer the full range of contraceptive choices at HIV prevention strategies at the same time and share with the same provider, and through an approach that is centered on women's informed choice. So again, it's this idea of integration. Preventing HIV and other sexually transmitted infections among women using contraceptive services in context with high HIV incidence was a presentation that was presented by UNAIDS. And some of the outcomes were that changes are needed to better serve adolescent girls and women at high risk of acquiring HIV and STIs who are accessing contraceptive services. And that approaches should be evidence-based and women-centered, people-centered, and that we should also prioritize the actions in settings with high HIV burden and improve access for women from key populations and in other vulnerable women and adolescents where HIV prevalence is low or medium. Faith communities in particular have been very instrumental in the fight to end HIV and AIDS in young girls and women. This is an opportunity for faith communities to continue that effort in terms of this integrative model of healthcare, where many faith communities deliver the healthcare that many of the young girls and women. There's really a point, again, to build bridges of collaboration where we can collectively increase the access for women and adolescents where HIV prevalence is high, but also where HIV prevalence is low and medium, making sure that we leave no one behind. We know that women want, need, and deserve more HIV prevention access and choice, that STIs in women are often asymptomatic and current syndromic approaches may not be adequate. And so there needs to be better diagnosis and treatment of sexually transmitted infections, including cervical cancer, and we need to act now. To continue this conversation around pre-exposure prophylaxis, Dr. Shauna Dalal presented a number of slides on different studies around the world that have compared event-driven PrEP or on-demand PrEP versus daily PrEP. It's evidence that there's a preference in some cases to certain forms of PrEP. There's a significantly higher retention in daily PrEP from some groups compared to event-driven PrEP. The good news is people are using PrEP correctly. And so that's something that we continue to celebrate as well. And then in the time of COVID-19, telemedicine is working well for people to be able to access PrEP. And so reducing barriers for people to be able to receive care, again, accessing treatment. But there still needs to be more work done around the uptake of PrEP. Dr. Dalal also presented around adolescent girls and young women, particularly slides on the impact of DREAMS, which is the Determined, Resilient, Empowered, AIDS-Free, Mentored, and Safe strategy that was introduced by the U.S. Presidential Emergency Fund for AIDS Relief, aimed at reducing HIV incidence among adolescent girls and young women in 10 countries in sub-Saharan Africa by 25% in the program's first year and by 40% in the program's second year. Likewise, in Zimbabwe, among young women who sell sex, there was a 12 and 24-month follow-up. Another ray of hope is that after the ECHO trial, there was a larger increase in the amount of women who initiated PrEP as a result of having been a part of the ECHO study. Jumps that suggest that if given the opportunity to be able to access preventative measures, but also care and treatment, that women will do so. Information for faith communities as we continue to work to increase access to prevention, treatment, and care in our key populations. And so there were a number of different sessions and virtual satellite presentations around men and HIV, particularly insights from sub-Saharan Africa. And one of the outcomes was that it is essential that health services acknowledge that we have been missing men, and that it is our collective responsibility for health systems to be people-centered to address the needs of all people. Key area for which faith communities can promote the human rights of men and young boys, and also work toward increasing access for services and care for men and young boys as well. Next, Cheryl Johnson from the World Health Organization presented HIV testing updates, beginning with some HIV self-testing highlights, which have become particularly important in the time of COVID-19. People are unable to access the normal care that they usually would be able to access. HIV self-testing becomes a viable option to make sure that people continue to know their status even in the time of COVID-19. And some of the key takeaways from HIV self-testing is that increased antiretroviral initiation, enhanced disclosure, and access for more men is one of the outcomes of HIV self-testing. We understand that there's no perfect test, but different optimization of delivery and support tools definitely help increase the availability of the test. That linking these tests and these outreach efforts with key messaging, again, continue to help people to participate in self-testing. Again, this word around integration, that we continue to integrate these services in other structures that key populations are already accessing. And so this is just a assessment of how countries are considering their scale up of HIV self-testing in the wake of COVID-19. And as you can see, all of the countries noted that the kits that they currently have are not sufficient and that there continue to be a number of supply chain interruptions that impact the availability for testing for people in sub-Saharan Africa. All right, the pediatric HIV lead at the World Health Organization, Martina Pinizzotto, presented on AIDS 2020 and children. Children are largely a function of the effectiveness of our response to women, but particularly mothers. This continuing rally cry to remind us that pediatric HIV is not done yet. We can't lose ground that we've already gained because we just might not recover, and we can't afford to leave our children behind if we want to get to an AIDS-free generation. So we have to continue to act now. We have to do more operational research, and we have to keep innovating. And as communities of faith, we have to continue to build bridges of collaboration with other civil society members, with the scientific community. Sessions reiterated that we have fallen well short of our 2020 targets, but there are some successes in mothers and children in spite of the limitations with the data availability. This idea of just social disruption and catalytic innovation is helping us to help women and to help girls and to help children to be able to know more about their HIV status around HIV treatment and care, but specifically some of the new regimens that are in the pipeline. No medication, no treatment is perfect. And researchers are always working to optimize the treatment availability. And so some of these studies have been around body weight gain and cardiometabolic effects of some of the new ARVs. While those ARVs have been successful in controlling HIV infection, some of the side effects have been unwanted body weight gain and some cardiometabolic effects. And so there's ongoing research to optimize ARVs so that they contain HIV without conflicting side effects. One of the key topics, not only at this AIDS conference, but in past AIDS conference, has been the safety and efficacy of new ARVs in pregnancy. At AIDS 2018, we heard about possible neurotube defects as a result of dolutegravir. And now we have more data that suggests that neurotube defects are significantly lower than initially reported, which is great news, but still higher than observed in those who are taking efavirenz or who are HIV negative. Two of the newest drugs in the HIV pipeline include lenacapavir, which is novel. It's the first in its class as an HIV-1 caspid inhibitor, and also islatravir, which is a dual mechanism of action. It is a nucleoside reverse transcriptase translocator inhibitor, which in and of itself is a new category of antiretroviral therapies. There was some interesting data presented in terms of the multiple mechanisms of action of islatravir that could potentially be substantial for people living with HIV as it becomes more tested and readily available. There was a segment during the AIDS 2020 virtual conference that specifically focused on the co-infections of tuberculosis and HIV. Tuberculosis continues to be the major illness causing death in people living with HIV, particularly in sub-Saharan Africa. And so any treatment for TB becomes a treatment for HIV. And there were a number of TB preventive treatment studies that were presented that continue to analyze impact of the prevention of TB, which we have treatment for, on people living with HIV, and how it continues to benefit us to be proactive in our fight against tuberculosis in our quest to end HIV and AIDS by 2030. Of course, there was a presentation around COVID-19, HIV, and tuberculosis, not just dual pandemics, but kind of a trifecta of these infectious diseases and how they might coexist, and whether or not COVID-19 deaths among people living with HIV, but also people who have associated co-infection of TB, how that might be quantified. And the conclusions were that they're twice the risk of COVID-19 death associated with HIV and TB co-infection. At the beginning of my presentation, I noted that the very first plenary session during AIDS 2020, three of the key points, the third being about financing and economics for ending the HIV epidemic. And I want to just conclude with a few statements around economics, but also social drivers as it relates to the things outside of science and medicine that continue to be barriers for us in ending the HIV and AIDS epidemic. There were two particular sessions about addressing the injuries and inequalities in HIV and AIDS pandemic, but also assessing the progress toward our global commitment, and a number of other sessions in this plenary as well. And while financing was not the main topic of these sessions, all of them were explicit to mention that there's this stagnating and decreased funding for HIV, and that the complexities to finance an optimal response, COVID-19 becomes this competing need and then creates this inequality. So now is when funds are needed the most, and now is when funds are faltering. As funds are decreasing and as resources are more stretched, social contracting with civil society organizations is going to continue to be all the more important as we continue an effective approach for our sustainable HIV and AIDS response. And that's going to include community-based organizations, and it most certainly is going to include faith-based organizations. And I really want to finish by really highlighting the importance of the faith community in these 2025 targets, but also in our targets over the next 10 to 20 years. Ambassador Birx said this about the role of community. She said, progress is not equal everywhere. We see this laid bare with COVID-19. The community voices must really be forefront in any messaging we have. This is what UNAIDS strategy will bring to us. It's that combination of data with communities and understanding the needs of the community, hearing the voices of the community, and the most importantly, investing in community and those voices. I believe that Ambassador Birx, who has been a longtime partner of faith communities to end HIV and AIDS, is speaking to us, speaking to faith communities and faith leaders in terms of investing in us and investing in our voices, understanding that our voices are critical, especially at this time in ending the HIV and AIDS epidemic. It was the first time that social enablers were listed as a part of the strategy over the next 5 years. I believe that all of these speak to what it is that communities of faith do best. Pew Research estimates that 84% of the world's population identifies with the faith. WHO estimates that 40% of sub-Saharan Africa's HIV treatment and care are provided by Christian hospitals and health centers, where it's 60% of HIV and AIDS services are delivered by faith-based organizations in some parts of the world. And it's critical that our voices continue to not only be heard, but continue to be out front in terms of increasing access, in terms of promoting human rights and building bridges of collaboration. But finally, in terms of eliminating stigmatization continues to kill more people now than HIV and AIDS does each year. And faith communities are in a particularly advantageous position to combat stigma where it originates. And what I really heard during this AIDS 2020 virtual conference, where it talked about integration and it talked about community-led interventions, I heard more and more a call for faith communities and faith leaders to be out front in this fight to end HIV and AIDS. We may have missed our targets this year, and we might not be on track to meet our targets for 2030. But without the involvement and leadership of communities of faith, we certainly won't get there. With communities of faith, with the partnerships of civil society, the scientific community, governments, and otherwise, I believe we can get closer than we've ever been. And I believe that it starts with us. And so thank you for your attention. Thank you for this opportunity to share just a few of the key points around science and strategy and process that took place at AIDS 2020. And I am available to answer any of the questions that you might have.